Dr. Putman is the Distinguished Life Fellow of American Psychiatric Association and a fellow of and member of American College of Psychiatrists. He's written a wonderful book, A Rational Psychopharmacology, a book of clinical trials and treatment for bipolar disorders. He's a practicing psychiatrist for over 30 years. He has also performed phase 1 to 4 studies in psychopharmacology. A very well accomplished psychiatrist, and he has published in peer-reviewed journals, served as a supervisor for Austin Graduate Medical Education. He lectures and consults regularly on psychiatric diagnosis, particularly in mood anxiety disorders. And he, as mentioned, he has a fully accomplished career, and we're looking forward to hearing more about his webinar today. A few things about the webinar. There's a message box on the right side, so if you come up with any questions, please type it in there. We will be answering all the questions at the end of the webinar. There will be 15 minutes Q&A question, and at that point we will be addressing. So over to Dr. Putman.
Thank you. Welcome. Thank you for coming to the talk. We're going to be talking today about critical lifestyle supports to accomplish successful clinical psychopharmacology. It's based largely on my book, Rational Psychopharmacology, a book of clinical skills, and this is taken mostly from chapter 9. So if you're interested in more information, all the references backing up what I'm saying are listed in there, as well as additional reading suggestions. So let's get started. Of course, when we're approaching psychopharmacology clinically, we're hoping to help our patients. And in order to help them, we have to have the brain function as well as it possibly can from every dimension, chemically, physically. And we have to therefore think not only about the primary illness that we're treating and the medications we might be prescribing and the psychotherapy we might be prescribing, we have to also think about the milieu in which the treatment is taking place. What else is impacting the brain? Sleep deprivation, depressants, drugs, stimulants, inactivity, nicotine, poor nutrition. And we're going to be going through many of these today. We're going to discuss sleep, exercise, weight and diet, alcohol, drugs, meaning recreational and illegal in this case, caffeine and other stimulants, and nicotine. So let's jump into sleep. Sleep is not only arguably the most important symptom for diagnosis, but also one of the most powerful non-pharmacological interventions. So therefore, you're going to want to be assessing it at every session. Our goal is for our patients to have a consistent schedule of sleep during the dark hours. And it's going to be necessary for them to target somewhere between 7 and 9 hours every night. This will be optimal. As you can see on the slide, there are some differences based on age. The average adult patient, we're going to ask to try to get 8 to 8.5 hours, a little bit less for older patients, and sometimes a lot more for younger patients. Our goal is for our patients to have a consistent bedtime within 1 hour of the same time every night and to get up within the same hour every morning, even on weekends and even on days off. It may, for patients who don't do this, they might not appreciate how much better they're going to feel when they do this. So you might have to predict that for them, but they will rapidly experience feeling better by getting up on weekends rather than sleeping in 3 to 4 hours. Offering a 1 hour variance may help with compliance, but we have to be clear that it still contributes to impairment. We know this from studies on daylight savings time in both the northern and the southern hemispheres, that every time there's an hour shift, there are clearly measurable physical and mental risks associated with that. So the other thing is important is blue LED light exposure. Now, most people are aware of this because of the media, and many electronic devices like your phone and your tablets and your laptops have programs that will help limit exposure to blue LED light. And you should encourage your patients to utilize these and self-monitor their exposure, because actually the blue LED light is going to decrease the natural evening secretion of melatonin that helps us get to sleep. So the bottom line is we want to limit bright light in the evening, and we want to expose ourselves and our patients to bright light in the morning. Let's take one example of sleep clinically, and that's shift workers, people who have to work during the dark hours. We know that regular shift work contributes to cognitive impairment, an increased risk of dementia, an increased risk of mood instability for patients with bipolar and similar disorders. It's been estimated that we can only approach within 20% of the ideal clinical situation when someone is doing shift work. We also have known for decades that shift workers have an increased risk of many forms of cancer. So with our patients, we have to be an advocate for them working towards day shifts. Now, you can't simply write a letter for them saying my patient must have a day shift, because that's an opportunity for them to be fired if no day shifts are available. So you have to work with them to figure out with their own employer what's the best way to move towards this goal. Sometimes a patient may have to change jobs if that's feasible. If not, however, medically, we have to, in good conscience, let them know that it's better for them to maintain the same day and night schedule every day of the week. Now, of course, it's not as good for socialization, and it's not as good for family life. But we have to give them the information that medically, if they have to do shift work, it's going to be a lot better to stay on the awake during the dark hours 7 days a week than to try to flip back and forth. What are some helpful interventions for our patients with sleep? Well, first of all, a drop in body temperature is necessary to attain sleep. So these temperatures, 68 to 70 degrees Fahrenheit, 20 to 21 Celsius, are necessary for the room temperature, allowing for clothing and bedclothes. We need to help our patients understand that they should think of the bed as being useful for only sleep and sex, never for lounging or studying. When the bed becomes the kitchen table, it's going to be behaviorally a lot more difficult for them to get to sleep. You can suggest foam earplugs. Many people can hear screams, shouting, important information, alarms through foam earplugs, but like a white noise machine, it kind of takes the edge off. Your patients may want to experiment and test these. And it's very important for you as a clinician to make sure that other concomitant conditions that will interfere with their sleep have been diagnosed and treated, such as nocturia. When patients get up to urinate during the night, they may be turning on the light. They need to not be doing that. Patients may not be aware they have sleep apnea, and many patients do, and they may not be aware they have narcolepsy. Those are going to be need to be investigated and treated in order to have good pharmacological outcomes. Other interventions. You want to discourage napping unless the patient is compelled by pathology, such as a patient with bipolar depression who's sleeping over 12 hours a day. They can't help that. But nevertheless, you want to teach them that afternoon naps are going to be more damaging than morning naps. Similarly, we don't want our patients eating 3 hours before bedtime. The body will still be digesting, and this is going to interfere with sleep. And same with exercise. Regular exercise 3 hours before bed will also be interfering with sleep. Alcohol limits REM and non-REM deep sleep. And like other interferences with REM and non-REM sleep, the use of stimulants, including caffeine, and some sedatives even, will predispose patients to a greater risk of memory problems, infections, cancers, and often shorter lives. It's okay for a patient to set an alarm after 8 to 8.5 hours have been allowed for sleep in the average adult, but it's not necessary, but it's certainly okay. However, we really discourage snooze alarms because body and brain physiology react poorly to repeated sudden awakenings. What we want to encourage for our patients with sleep is a natural daily rhythm. Some people think that they're supposed to go about their day actively until they are struck down by sleep, like a lightning bolt. And we have to help our patients understand that this is not accurate. A sleep is a decision made on a schedule, that they need to allow time for slowing down. They need to adjust to reduced or indirect lighting. They need to actually close their eyes, and they need to actually tell themselves, okay, now I'm going to go to sleep. Some people do this, but you might be surprised how many people don't. Let's look at another crucial clinical example, and that's when we're worried about a patient developing postpartum depression or psychosis, the closest thing to a true psychiatric emergency. You're going to need to plan ahead to protect the mother's sleep. We're going to assume the mother is the patient in this case. You're going to need to talk to the family and the patient to arrange for feeding and caring for the infant during the night, because waking to feed or soothe the infant is likely to provoke an episode. The family has to understand that the mother as the patient cannot be disturbed during the night. The reverse is, of course, true if only the partner carries the risk of mood episodes. In the unfortunate event where someone is awakened, make sure that no bright lights are turned on, because that's just going to make things worse. Our goal is to initiate our treatments only in the context of good sleep hygiene. Patients' brains and bodies must be in sync with our efforts to restore natural psychoneurological and endocrine function via pharmacological and somatic treatments. There is cognitive behavioral therapy for insomnia, but really when you get into it, it's sleep hygiene. It's the things I've just been telling you. It's not what we think of as traditional cognitive behavioral therapy. Remember that sleep must be protected because you need it for good clinical outcomes, and it's also an important tool of assessment as well as the focus of treatment. Now let's move into exercise. Patient interest varies in exercise. There are methodological problems with studies attempting to link exercise and mood and anxiety improvement, and it appears that genetic factors may be involved. In fact, a brain-derived neurotropic factor is depleted in patients with major depression and is enhanced by moderate, prescribed, regular aerobic exercise. So this might point to a therapeutic mechanism. Is type of exercise important? Well, at one time, we thought it was. We thought that anaerobic exercise producing oxygen debt was much more likely to provoke anxiety symptoms. We now know that it's actually the fitness of the patient and the severity of their anxiety disorder that is important more than anaerobic exercise. This is a good this is a good clinical example about this issue with panic disorder. Early in the 1980s, when panic disorder treatments were being uncovered, it was found that lactate infusions would provoke symptoms. And it was known that that time it was thought that lactate was produced anaerobically. So therefore, anaerobic exercise was once thought to be solely responsible for this buildup and to produce panic attacks and other forms of anxiety. We've since learned that lactate is produced aerobically as well as anaerobically. So this theory was incorrect. It's much more true that a risk of inadequate training or acclimatization to altitude is going to provoke panic more than just having lactate in the system. Similarly, for any reason, increased respiration or increased heart rate can also provoke panic episodes. So it's going to be the unconditioned patients that are the most sensitive to exercise-provoking panic disorder. So what is the preferred exercise regimen? Well, you're going to want your patients to avoid sudden bursts of physical activity. A better plan is regular exercise through progressive training methods. You start slow, you start light, you build gradually. We know that this will actually increase the metabolism of lactate by mitochondria in the liver, kidneys, and the heart. Our goal is healthy exercise in moderation, taking the patient's physical condition into account. It should only replace indicated psychopharmacological intervention with a clear reason, but it may enhance the pharmacotherapy. You're going, with all interventions, of course, you're going to need a strong therapeutic alliance with your patient to make sure that you blend their ideas about exercise and all the other health factors we're talking about and your ideas. Now let's talk about diet and weight. Now, diet, of course, may be influenced by symptoms, and therefore patients may not be in control of their weight and hunger, particularly early in treatment. There are also appetite and therefore weight effects of diagnoses, and there are weight effects of some treatments. So that's why dietary planning is very important as part of your pharmacotherapy. Our goal here is a moderate appetite and weight without inducing any additional health problems. Now, the BMI is commonly used and, of course, is not perfect. You can read that everywhere. It overestimates fat in extreme athletes and those with other excessive muscle mass and in pregnancy, and it underestimates fat in geriatric patients and other conditions with muscle wasting. And it's completely invalid for children, adolescents, and those with eating disorders. Nevertheless, the calculators are everywhere on your phone and on your laptops and maybe even in your electronic medical records. It is a better than nothing method of discussing weight and for monitoring progress. So what will effective weight planning look like for our patients? Well, it's best to really just avoid motivation and excuses and reduce it to simple arithmetic. Basically, you can think of 1 pound of weight as 3,500 kilocalories, and we know as professionals that kilocalories are what people call calories. So basically, if you change the net intake of calories by 500 calories a day, a patient should either gain or lose about 1 pound a week. Now, recent research has shown that this is a rough estimate for moderate weight loss. It can be distorted by sex differences, the original amount of body fat versus lean body weight, and metabolic changes that occur during the weight loss process. And for these reasons, the actual weight loss might take longer or even stall, the latter more commonly resulting from waning patient compliance over long periods of time. This is a long-term project that should lead to permanent lifestyle change. What I recommend we do is have our patients go online with you and calculate their current calories that they must be taking every day to maintain their current weight, and then reduce it by 500 calories per day, and then calculate the time it will take for them to have an average 5-pound weight loss, which should be somewhere around 5 weeks. And then ask them to mark that on the calendar so that 2 to 3 weeks into treatment, when the patient is very discouraged because of all the effort they're putting into weight loss and not seeing much of a change, they won't give up. They realize that the goal is further down the road. And I want to also say that although increasing exercise is equally likely to produce changing the calorie intake, many patients find it easier to manipulate the dietary intake than exercise. So for those patients, that might be a better focus. Diet offers more opportunities for change than activity for many patients, although you want to take that individually. So what we're offering our patients is strengthened dietary intake control, which will be a useful skill for them. We're helping them take a long-term view that can be accomplished through small daily changes. What are some additional resources? Of course, Weight Watchers is a behavioral and support method that's very effective for many people. And then Overeaters Anonymous is a very effective 12-step program. I want to also mention a book called Mindless Eating by Wansing. This is a marvelous book. It's really, really good research that shows the general public how they often eat when they're not thinking about it, or they eat more without the intention of eating more. And it can help us be more consciously aware of our behaviors and cut down on needless calories. All right, let's move into alcohol. Alcohol is, of course, a central nervous system depressant. Ideally, all psychopharmacological intervention would occur in the absence of alcohol, as it is likely to complicate symptoms and treatment success. Our best recommendations to our patient must always be, it's frankly better without it, because we can never promise them that it's not going to have an adverse consequence. It's also very important that you make your diagnosis once the patient has been off of alcohol for at least 14 days. This is particularly true in mood and anxiety disorders. You can really get a false diagnosis if alcohol is distorting the picture. So again, we have to always maintain that it might always interfere. So we're going to need to be assessing for how much alcohol patients are using at every contact. If we're asking them to change the amount of alcohol, we need to also try to avoid and monitor for alcohol withdrawal. What's a good way to help with the taper or cessation of alcohol? Well, medically, it's generally safe to reduce as rapidly as 20% a day, although that's a little scary and probably not terribly practical for outpatient treatment. What works a lot better for outpatient treatment particularly is to ask the patient to reduce their total alcohol intake by 25% weekly. So if you're doing this at a certain session, you're probably going to want to reassess in about 5 weeks, because that will include the 14 days washout period without any alcohol. You just have to be extremely clear with them that you really literally mean not 1 drop of alcohol in the 2 weeks before you see them again. Now, of course, we don't want to be provoking alcohol withdrawal. So we need to be monitoring blood pressure, pulse, and the symptoms of withdrawal, including sweating, tachycardia, hypertension, nausea, tremor, cognitive impairment, even delusions and hallucinations. And you want to review these with your patients in advance so that should these occur, they'll be able to contact you and intervention can take place. So after the washout of the 14 days, so that you can make the accurate diagnosis and hopefully begin treatment, it's good to continue to encourage further avoidance. Sometimes you might have to negotiate a little bit of alcohol because a patient just absolutely refuses to stop. And what I found very helpful is sometimes allowing 1 ounce or 1 drink twice a week, no more, and never on the same day. Patients will often readily agree to this, and many of them will find that they don't even need to drink that much. It's just nice to have the permission. The other thing that's important for them to know is that beer and wine have just as much alcohol as a mixed drink. 1 ounce of alcohol, or 30 milliliters, is the same in 1 beer, 1 mixed drink, and 1 8-ounce glass of wine. Another thing that's useful is to suggest alternatives. When everybody else is having a drink, maybe they have something special that they get to drink too. Sparkling water, special juice. Just please try to make it not have caffeine, as we're going to get into later. All right, and then of course, recreational and drugs of abuse. Whether or not you're thinking these should be legalized or not legalized, we have to admit that they can affect treatment outcomes. So you're going to need to be asking everyone about this at every visit, even when it seems ridiculous. We've all had the experience of asking our nice 65-year-old lady we've seen every day, every month for 20 years, if she's ever used marijuana, only to say, oh yeah, my friends and I tried that for the first time last week. So you can be often surprised. So ask everyone at every visit, because it's going to affect your treatment outcomes. Although cannabis has been legalized for medical use in many U.S. states, this is most commonly for the treatment of cancer pain, glaucoma, HIV/AIDS, cachexia, severe chronic pain, muscle spasms, nausea, seizures. Studies of its efficacy in these cases actually remain equivocal. Additionally, claims of benefit for cannabis in psychiatric, developmental, and neurodegenerative disorders are also poorly substantiated. There's a large group of synthetic cannabinoids available to provide medical benefit without the psychoactive motivation that leads to recreational use or abuse. Most of these, sadly, though, have not received adequate study either. Two are legally approved in the US and the UK, dronabinol and nolibolone for refractory nausea and emesis during chemotherapy. The former is also used for anorexia in HIV cases. Nabiximols is available in Europe, the UK, and Canada for treating neuropathic pain, spasticity, overactive bladder, and other symptoms of multiple sclerosis. It's reasonable if a patient is self-treating with, say, cannabis or something similar for, say, panic disorder or social anxiety disorder, through your therapeutic alliance to agree to slowly taper the recreational drug and to slowly increase an effective and safer treatment. That's perfectly effective and permissible. So it's, of course, very important to stress that every intervention in the treatment plan should support brain health because we're allowing the brain to function as well as it can and lead to symptom resolution. And therefore, you want to treat primary substance disorders first before you go back and try to diagnose other conditions. In order to do this, you have to know how long the substance is going to be in the body. You've got to learn their half-lives. And you can see on this slide that there's a list of many different half-lives. Heroin is brief as 30 minutes, cocaine 1 hour or less. Look all the way at the bottom of the list to the effective half-life of cannabis. Now, effective half-life means it's the half-life of the parent compound added to the half-life of active metabolites. And we're looking not at hours, we're looking at 67 days. Marijuana or cannabis is stored in the fat cells in the body. Those fat cells are broken open and turned over about once a year. It does release the cannabis into the bloodstream. Probably not enough for someone to get high, but enough that it can be picked up on some drug screens and it might interfere with your pharmacotherapy. So it's very important that you get rid of these things as fast as you can. Now, it might not be practical for you to wait an entire 6 to 12 months to start treatment while the cannabis leaves the body. But nevertheless, knowing these half-lives can help you understand what's going on and titrate your expectations about their treatment success as you go forward. All right, now let's move into caffeine and other stimulants. And I predict that you're going to have more arguments and disagreements with your patients about caffeine than you are anything else we've talked about. There's a lot of misunderstanding about caffeine, and you can be very helpful by helping patients learn about it and make important lifestyle change here. Caffeine is in prescription medications like Fioricet, Norgesic, and prescription decongestants. It's in many over-the-counter products, such as BC powder, Midol, most Excedrins, Goody's headache powder. It's in Dexatrin. It's in the nasal spray Dristan as a stimulant. And also pseudoephedrine is a very common over-the-counter stimulant that's going to be causing problems in many patients. We want to talk about the content of caffeine in substances the patients might be using. The average soft drink with caffeine has 30 to 40 milligrams of caffeine. Look here, green and black tea also have about the same amount. For some reason, people tend to think green tea doesn't have caffeine. No, it has the same amount as a soft drink. Coffee has about twice as much. Energy drinks have enormous amounts, and chocolate has caffeine, all chocolate. Dark chocolate, as you see, has more than milk chocolate. White chocolate by itself isn't supposed to have caffeine. However, it's often added by the manufacturer, so you need to ask your patients to check the ingredients to see if it's added. Decaffeinated products still have about 10% of the original amount of caffeine. In coffee, a dark roast decaffeinated like French or espresso roast, however, has less, maybe a 1% chance. There are decaffeinated products where the caffeine is removed, and then there are caffeine-free products where it never was there in the first place. So help your patients understand that if they're making a choice, choose the caffeine-free products rather than the decaffeinated products. Also, a big problem, particularly with teas, is the term herbal. Many people think herbal teas don't have caffeine. Herbal has become a marketing term, and there are many commercially available, quote, herbal teas that do contain caffeine. So again, teach your patients that they need to be looking for the words caffeine-free. Determine with them whether their soft drinks they're consuming contain caffeine, such as Mountain Dew, Dr. Pepper, Coke Zero, even Big Red, Sun-Kissed Orange, and A&W cream soda, or whether they don't contain caffeine. A&W Milk Root Beer, Ginger Ale, Sprite, Fanta, Diet Right Cola, Fresca, Sierra Mist. You can't guess, you just have to check. So-called zero soft drinks are referring to calories, not caffeine. And a single brand may have both caffeinated and caffeine-free products, such as A&W with their cream soda and their root beer. Energy products often contain caffeine. Since ephedra was banned in the US, thankfully, in 2004, if a product's going to promote energy, caffeine's one of the few things they can put in there to give you a buzz. And remember that green tea, as I said, has caffeine. Often, energy products will hide the caffeine by describing it as green tea extract. So you should alert your patients to that. And of course, energy drinks are going to have a lot of caffeine and other stimulants that are adverse for your patients. Okay, so let's talk about caffeine metabolism so we can begin to talk about why it's such a bad thing and why you want your patients off of it in most cases. The half-life of the parent compound is about 2 to 12 hours. Caffeine is widely distributed throughout the body, and it's largely metabolized by cytochrome 1A2 of the P450 system. Although xanthine oxidase and N-acetyltransferase 2 also have some influence. Its active metabolites half-lives of pyrazanthine and theobromine are 2 to 12 and 8 to 12 hours, respectively. And your levels of pyrazanthine often rise 8 to 10 hours after ingestion. As you can see, because caffeine is being metabolized by 1A2, it's going to increase the level of some medicines that are important, and the caffeine itself is going to be increased by other medications. So this is going to have often an important clinical effect on your patients. There are many antidepressants, and including duloxetine, imipramine, amitriptyline, clomipramine, in addition to the atypical antipsychotics clozapine and olanzapine that are affected by caffeine. Fluvoxamine is an interesting case study. When that became available, and it was originally marketed for OCD in the US, even though, of course, it's an antidepressant, suddenly all of our patients on it were getting very, very anxious and having a lot of extra anxiety we weren't anticipating that didn't show up in the controlled trials. And we learned that fluvoxamine is a strong inhibitor of 1A2, and therefore it was bumping the levels of caffeine in the bloodstream 5 times. So it was very important that those patients be tapered off of caffeine in order to tolerate the treatment. Verapamil, a commonly used medication, is another strong inhibitor, as are estrogens and disulfiram. The stimulant clinical effects include increased anxiety. They can provoke bipolar symptoms. They can decrease sleep, and we've already talked about how bad that is. They can decrease physical energy. Your patients won't believe you at first. They'll say, I have to have the caffeine for energy. But actually, well-conducted physiological studies have never shown beneficial effects. there's only a subjective perception of fatigue that might improve while taking it, because caffeine has no positive effect on power. Predict for your patients that a month off of caffeine, they're going to have more physical energy than they have now, both through the less tension and through improved sleep. You can read in the media every now and then how coffee will prevent dementia. There are some components of coffee, chlorogenic acid, quinic acid, caffeic acid, quercetin, and phenylalanine may inhibit amyloid or tau aggregation associated with dementia. But it's very clear that the caffeine itself is not responsible for these potentially neuroprotective changes preventing dementia. So how do we help our patients get off of caffeine? Well, remember that a significant withdrawal syndrome may develop that's uncomfortable and never clinically necessary. So discourage enthusiastic patients from stopping abruptly and predict for them the expected results if they do, such as headaches, fatigue, anxiety, irritability, mood changes, tachycardia, tachypnea, so that these symptoms won't be confused with the primary symptoms or with the new medication you're prescribing. What works very, very well over and over again is to ask your patients to cut their use of caffeine in half for 1 week and then stop it completely. Almost no one has caffeine withdrawal when they do that. If they're particularly afraid to do that, or if they are an extremely heavy user, you can go ahead and say, half the use for week 1, cut that amount in half for week 2, and then stop it. And I predict you're almost never going to have a problem. All right, let's move on to nicotine. So, clinical psychopharmacologists must be aware of how smoking and nicotine may alter symptoms in successful treatment. The percentage of patients who's diagnosed with psychiatric disorders who smoke is twice that of the percentage of smokers in the US general population, 41% versus 20%. And we're constantly seeing newer and newer delivery methods of nicotine. So it's very important as a clinician that you be up on those. As you can see, nicotine metabolism also goes through 1A2, but also 2A6. The enzymatic induction produced through the polycyclic aromatic hydrocarbons in the smoke lowers the level of many antidepressants and antipsychotic medications utilizing those enzymes. You can see a list here from caffeine, which isn't a terrible thing, but the medicines we might want to be using are lowered, such as even zolpidem, and as we said, antidepressants and antipsychotics. So changes in smoking then must be monitored in patients using these medications to follow the rises and falls in serum levels. Let's look at a clinical example. And schizophrenic patients who've been diagnosed with schizophrenia, 60 to 80% of them smoke, and they smoke in higher amounts than other people who smoke. It has been found that among patients with schizophrenia who are smoking, they have lower extrapyramidal side effects of their medications and less akathisia. That makes sense because, of course, the level of the medications are lower in the blood. And we also know that there's higher smoking rates when first-generation antipsychotics like Haldol are being used compared to the second generation or the so-called atypical antipsychotics. Nicotine cessation is a primary public health goal for these patients with schizophrenia because long-term use is deleterious. Depression and major depression and mood instability in bipolar disorder can be provoked by nicotine reduction or cessation apart from nicotine withdrawal, although ultimately mood improvement might be seen. So for this reason, nicotine should usually be tapered cautiously and often slowly over several months in these patients. In some cases, even reduction provokes so many symptoms that the cost and benefits are going to have to be weighed at least temporarily. What are some smoking cessation strategies? Well, there's e-cigarettes, bupropion, varenicline, and transdermal nicotine patches are someone we're going to discuss. Let's talk about the e-cigarettes. Some smokers tend to use e-cigarettes to slowly taper their nicotine content, allowing them to eventually cease use altogether. Some data supports that plan, but there are many other smokers, however, who continue with regular use. In fact, many nicotine users continue both the traditional cigarettes and the electronic e-cigarettes. So patients should be made aware that the e-cigarettes may not be safer than traditional cigarettes. They are not well regulated, they still contain toxins, and they're not proven cessation devices. They've been banned in many US states pending FDA evaluation because they've been linked to greater than 2,700 cases of lung injury and greater than 65 deaths as of this talk. Another thing that your patients need to be extremely aware of is that the vaping fluids that contain flavorings may be particularly dangerous, particularly if they contain vinaldehyde and vanillin and other aldehydes, or decompose into them and represent a toxicity risk when inhaled, even though they are safe when taken orally. Patients should be informed of these risks and advised to use e-cigarettes primarily to aid smoking cessation and to completely avoid aldehyde-related flavorings. They should discuss this aldehyde toxicity with the vendor of their product and change sources if the ingredient information is not readily available for them. Now let's move on to bupropion. The efficacy of bupropion in helping with smoking cessation is well documented, and the response is dose-related, meaning that you get more response at the 300 milligram daily dose than you do at the 150 daily dose. It's important to remember, though, that bupropion is still an antidepressant. So in a case of bipolar disorder, you may not want to be using it because, of course, you might provoke mood instability. And similarly, if a patient's already on an SNRI where norepinephrine is already being addressed, it might not be well tolerated there either. So you have to put that in perspective. Now, varenicline, or Chantix, has adequate supporting data. Early on, there were many clinical reports of worsened mental health symptoms from being on this agent. However, we now show little concern with further study. Meta-analysis found no increase in suicide, There we go. Where was I? Oh, yes. Meta-analysis shows no increase in suicide, suicidality, or depression with its use, but there was evidence for an increase in insomnia and abnormal dreams. So you want to have a full discussion with your patients and maybe their family when they're choosing varenicline as the first agent for nicotine cessation. The transdermal nicotine patch is well tolerated when used properly. It's effective with motivated patients, and it's safe when used as recommended. Early on, there were some reports of sudden death from patients using the transdermal nicotine patch and smoking on top of it. The nicotine's half-life is about 2 hours. So what works very well is to recommend a 2-hour window between any use of nicotine and any use of the patch. For example, a patient who's going to go on the patch would stop their use of nicotine, wait 2 hours, then put the patch on. The patch should be used for 24 hours. But if some reason somebody just can't stand it, wants to take the patch off and smoke, have them take off the patch, wait 2 hours, and then use the nicotine. Obviously, you're not going to be making a lot of progress that way, but it will be safe. What is the dosing for the transdermal nicotine patch? Well, if a patient is using 20 or more cigarettes per day, you're going to want them to start with a 21 milligram patch. And you want them to use it daily for 28 to 42 days before reducing. Back when these were only by prescription, these were the recommendations. However, when it went over the counter, many patients had to pay for it themselves. They said, oh, I can't afford that. So the manufacturer said, oh, we'll cut it in half. Well, but there's no data behind that. You really need to stick with the original recommendations. So 21 milligrams for 28 to 42 days, then drop down to the 14 milligram patch daily for another 28 to 42 days, then drop down to the 7 milligram for the remaining 14 to 42 days. Don't just quit using it. If a patient starts out with a nicotine use that's less than 20 cigarettes per day, as you can see, 10 to 19, go ahead and use the 14 milligrams for the full period, followed by the 7 milligram. And if they're really just using less than 10, you can probably just use the 7 milligram. Again, with bipolar disorder and mood disorders, a much slower taper might be preferable. Moving the patch to different locations each day may reduce skin irritation. Efficacy has been found for every form of nicotine replacement, including gum, nasal spray, lozenges, but there's a clear endpoint with patch use that often produces effective results for motivated patients. A handful of studies have investigated combining the patches with deliveries of nicotine and found it to be safe and helpful, as we discussed. However, you have to take into account the total amount of nicotine the patients are consuming and their individual health status. If you're using the patch with a prescription of varenicline or bupropion, however, you wouldn't be having that same risk. So what are our key points from today's talk? Well, first of all, good sleep hygiene should always be prescribed. Gradually progressive exercise may support, although not replace, indicated psychopharmacological treatment. We need to be teaching our patients simple calculations to manage their weight. The unfettered use of stimulants, both by prescription and over the counter, may well lead to treatment failure. The use of alcohol and recreational drugs may compromise diagnosis and treatment success. And however nicotine may influence symptoms and side effects, in the long term, patients are better off not using it in any form. I want to thank you for coming today. This is my contact information. You can reach me through LinkedIn or go to my website. There's additional information there and ways to contact me. And I'd be happy to open it up for questions at this time.
Thank you, Dr. Putman. That was really, really interesting, and we got a really good insight as to how to manage ourselves with pharmacological drugs as well as on our own. So are there any questions? Can you all type them in this chat box? Does anybody have any questions? So it was very interesting, Dr. Putman. You were earlier we were talking about how much amount of time do you think if we do meditation throughout the day and yoga, would this help us supplement treatment with?
Yes, we were discussing that there is good clinical data showing that some forms of yoga with meditation can be very helpful for patients. We were taking the case of primary caregivers of chronically disabled people, which we know have a much shorter lifespan. And we knew this for years. We didn't know why it was. We now know it's because the person's immune system is aging prematurely, and that never comes back. But there has been data showing that with yoga and meditation, that actually the outcome can be much happier for the caregiver than without that. So that's another lifestyle change that would be very helpful for caregivers, not just patients.
I see. Also, what about what parts of the diet? There's a whole like a diagnosis in the diet that we should be eating, like gluten-free, and in those areas. Would you be able to give us your thoughts on that as well? So, for example, which diet we should follow with which medication, anything like that?
Well, of course, if you have a patient on a monoamine oxidase inhibitor, an older antidepressant, they're going to have to be on a tyramine-free diet. But apart from something that specific, it's really what works best for the patient. Obviously, if a patient has celiac sprue, they have to be on a gluten-free diet. Other than that, you're going to find that most patients have a lifestyle and a diet that's going to work best for them. And in most health cases, that's just fine. The important thing is that the patient be given tools to make sure they have more control over their appetite and more control over their weight through their diet. So I'd individualize it very much. I wouldn't say that everybody needs to be on a certain diet because physiologically that's just not simply going to be true. Work with your patients to figure out what works best with them and then go with that.
Okay, fantastic. There recently has been like a fad for intermittent fasting, and a lot of there have been research studies about intermittent fasting and a fasting period. So it's interesting that each patient would have to follow a separate diet.
Yeah, the intermittent fasting has been known for some time as being associated with longevity, that the people who do fast appear to live longer than others who don't. Again, large groups versus large groups. You can't always extrapolate down to one single individual. And again, it's probably very important to realize that whereas that might be somewhat helpful, it might not be advantageous for someone else. Someone with hypoglycemia going to need complex carbohydrates at regular intervals. So again, taking the health situation of your patient needs to come first. Assess that and know what the best diet for them is physiologically, and then use this other data to put on top of it.
That's very helpful. Esther, Latrivia, any of y'all, do you all have any questions? Any comments? Esther said, good presentation, doc. Slides show light exercise prevent lactate in unconditioned patients.
Yes, yes. Very much conditioning, building up, whether it's altitude or whether it's exposure to exercise, you're going to have a much better metabolism of the lactate in the tissues if you're helping them build towards the exercise level progressively.
Super. James, and Laura and Tony, do you all have any comments on the presentation? Any clarifications? Reena, Madhuri, any of you all would like to chime in and make any comments on the presentation? Laura is saying that it was really helpful. How do you believe a patient's confidence who's struggling to believe in benefits of medication?
I think it's very important that always to share the outcome studies that you're aware of. We make decisions about prescribing medications based on outcome studies, not theories. That's one of the central tenets of my book. And so therefore, you're going to be aware of the outcome studies and information, and you should be sharing that with your patients, of course, when you're discussing the medications that might possibly be helpful for them. So you're giving them the probability of a positive outcome, and of course, without revealing specific identifying information, you can tell them of vignettes of other patients you've treated and the success they've had. We, of course, never are able to promise that, but we can give them probability. We can help them understand what that probability is. And it's very important to help them understand that maybe the first treatment we're going to choose doesn't turn out to be right for them. We're not right 100% of the time. But we're going to be working together to change our model of what we think their problem is if we have disappointing results until we get the right model of what the problem really is and find the best pharmacological solution. If you're with your therapeutic alliance, working with the patient to share all the information you have about with them at the same time you make decisions together, I think patients are going to be much more open to considering medication.
That's fantastic. I think that Laura, do you have any questions or comments on that? Okay, she says thank you. We have one more question. Are the psych NPs allowed to treat qualified patients with approved medical cannabis?
I'm sorry, would you ask that again?
Are psych NPs, nurse practitioners, allowed to treat qualified patients with approved medical cannabis?
That's, of course, going to be regulated by each government. In the United States, that would be by each state. So I'm not familiar with the laws in every state. So you would need to find that out at your state. But there are states in which nurse practitioners are fully licensed to practice independently with psychopharmacology. And as I said, there are many states in which medical marijuana is allowed to be prescribed. So yes, there would be circumstances in which that would be allowed. You would just have to look at the laws of your individual state.
Okay. Okay. I guess we're coming to the close of our webinar. Does anybody else have any comments before we take off? Okay, thank you, Dr. Patman. It was a very enriching and informative webinar. Thank you so much for your time. And thank you for attended the webinar as well.
Thank you.
Thank you.
Take care.
Okay, bye-bye.